So welcome everyone. Welcome to Her Body and Mind. I am Amanda Sarich and this is
Dr. Sierra Fox.
And today is our second of our 3-part series on everything iron. Today we're going to be talking about assessment, which is exciting. And so today we're going to talk about labs we use to assess iron deficiencies, labs that we can use to differentiate like what isn't an iron deficiency. We can talk about how to know when you're iron deficient without even doing lab work. And then we're going to talk about like optimal ferritin. What's our goal here? What's like the best case scenario?
Yeah.
So I'm going to learn a lot this episode, as I did in the last one. Had quite a few aha moments on episode 1 of this 3-part series. So we'll see if I have more today in this one now. So let's talk about the first question is, what labs do we run, Dr. Fox? Tell us the labs.
Yeah. So I know we touched on like a few of them. We differentiated like terminology in the first episode as far as like what is the difference between iron deficiency and anemia? Because those are two very different things. And so when we're looking to do like an iron workup, we are kind of looking to assess both iron deficiency and anemia. So if you're unclear with the definitions, go back to the other episode and it's clearly defined there. But today we'll just talk about the labs. So we're looking at doing a CBC, which is showing characteristics of your red blood cells and your white blood cells. And then we're looking to run your ferritin. We're looking to run your CRP. So that's one that a lot of people don't really know a lot about as far as CRP. So I'll get into that in a second. And then sometimes we're doing transferritin saturation. And as far as actually testing iron, because a lot of people, when we talk about iron, they're like, I want to test my iron. Like, let's just test the iron. Like, they're like, what's this ferritin stuff? Like, we don't care about ferritin. I want my iron done because I think because it's the word iron, it's going to be better or give them more specific information. But iron's actually not that useful. The only thing we really use your iron to determine is if there's actually something like hemochromatosis, which is iron overload, or if we're trying to calculate total iron binding capacity, which is a marker that can kind of just tell us inadvertently like more about your iron deficiency, not necessarily an anemia. And so iron's not useful. And not only that iron in itself as a lab test can be influenced by how long you've been fasted for. And so depending on how hungry you are or how long it's been since you've eaten, that level will change. So it's really unpredictable.
Interesting.
Yeah. So a lot of people don't go in with the education of like, I should fast or not fast or whatever. So it's not super helpful a lot of the time, but never say never. Sometimes we do need to run it. Now, going back to CRP, have you heard of this?
No, that's a new word for me.
C-reactive protein?
Still new.
Okay. So that's a marker of inflammation. So I never run a ferritin without doing a CRP. And there's a very specific reason as to why we need to do that. Not all practitioners will align with me being like, well, unless there's like concern about some sort of inflammatory something, then we're not going to run this. But you don't know who's struggling with like non-alcoholic fatty liver disease that then is throwing off a bunch of inflammation in their body. Like, so CRP, if you're inflamed, and this is a non-specific marker. So it shows that there's inflammation in the body, but it doesn't tell you like, where is it coming from? But it doesn't matter. When it comes to CRP, what matters in relation to us assessing iron or iron deficiency is that if your CRP is elevated, it will falsely elevate your ferritin. So let's pretend that you had a ferritin of 100. So that's perfect.
Dare to dream.
Perfect ferritin.
Great.
And your CRP was 10. So that level came back as 10. We know that the ferritin, realistically, if we're just looking at ferritin in relation to your iron stores, you would have to cut that number at least by half, if not by 2/3, to realistically then show where you're actually at from an iron store perspective. So really you'd be closer to a 30, maybe 50, even though the ferritin looked like it was 100. So if you don't run CRP and someone comes in and you're like, oh yeah, your ferritin's 100, you are great. Again, like the patient thinks that their iron is normal when it is not.
Look what we're learning.
Yeah. And when you're inflamed, here's like another like nuance about inflammation is that your body wants to protect yourself because it thinks that whether it's fighting an infection. So something called hepcidin, which is a constituent in your gut lining, it's like the gatekeeper. It's like the guard. It's what tells your body how much iron you will absorb in the gut. So when you're inflamed or if you're sick or if there's infection, that level will increase, which blocks your absorption of iron.
Huh.
So whether it's through dietary sources or supplemental sources, you just won't get as much out of that because it's literally shutting down the gate and saying like, we're not letting iron in right now. So if you're inflamed, you're more likely to have that level higher.
Interesting.
Anyways, that's like testing or like the testing that we're looking specifically for iron deficiency.
Okay.
Yeah.
So what labs would we test to rule out other things? Because in the last episode too, you talked about how so many of the symptoms of iron deficiency can be so many other things. And so how do you like go about determining like what is like what?
Yeah. I mean, there's a lot of things that we can't test for, but the things that we actually do have relatively easy access to from like in BC Life Labs perspective, or there's other labs in BC, but just come up from like a serum perspective that your GP or naturopathic doctor or nurse practitioner can run. It would be looking at your B12 levels, your D, so vitamin D levels, a full thyroid panel, which you know a bit about.
I do, because I have Hashimoto's disease.
Yes.
So I know a lot.
Yeah. Tell us a little bit about like TSH, T4, T3. Do you remember the differences?
Well,
Ish.
no, but I know that I have to take Synthroid every day to keep my TSH stable, which I've like found a good dosing, and it's like always really good over the last like 5+ years.
Yeah.
And I know what it feels like when my TSH is off and how fatigued. Like in high school, we would go to high school and then I would go home and I would have a little nap while Sierra hung out as teenagers while Amanda took her little after school nap, which we just thought was me. But actually I probably had this my whole life and I was just so tired all the time, even as a teenager. So
if you wanted to be friends with Amanda, you had to put up with her nap.
You had to nap. So yeah, but sidebar. Yeah.
Yeah. So that's, I mean, in retrospect now in my clinic, when I see a teenager or even an adolescent and they're telling me their kid needs to nap after school, I like have this beautiful example.
Just watching me
Amanda
sleep.
me like, she was actually hypothyroid her whole life. And it's not normal to nap after school, people, just so you know. Or even if you're an adult, you need to nap halfway through your day. No. There's something wrong. I digress. Yeah. So full thyroid. So when she says Synthroid, that's actually T4, or it's a synthetic form of a hormone in our body. So T4, T3 are the active hormones. Those are the things that actually dictate energy. TSH isn't the thing that dictates our energy level. It's just a signaling molecule in your brain that tells your thyroid to produce active hormone. So though TSH can give us hints, it's not the full story. If that's all you're getting done, please find a way, whether that's working with a naturopathic doctor, to get the full panel run. So TSH, T4, T3, anti-TPO for autoimmune screening. And there's actually something called anti-TG that is also part of like an autoimmune screen. So that's a full thyroid assessment. Then other things that we're looking for, you might actually want to do a celiac screen, and that's for like, again, absorption issues. Like if your iron's low, but your periods are light and you eat meat, like there's a reason why your ferritin would be low. So you also want to rule out conditions that can cause low iron or block your ability to absorb. I just want to see what else. Testosterone. So we touched on this. Was it the last episode? Yeah. About testosterone. So that again, like as far as mimicking similar symptoms, low T can feel like low motivation, low energy, low moods, but so can low iron. Same with B12, like they present all very similarly, right?
Absolutely.
So that's important to screen for. And then blood sugar as well. So looking at hemoglobin A1C, which is your average blood sugar in the last 3 months versus fasted levels. So fasted insulin, fasted glucose, those are looking at, have you been able to bring your blood sugar back down since your last meal 12 hours ago or longer? So a lot of people will get kind of dizziness and fatigue and crashes after they eat meals or between meals when they shouldn't. And it's because of a glycemic issue or an insulin resistant picture. So that's also important to factor in when we're doing testing.
So if I went into my GP and I was like, I'm really tired, like I'm so fatigued, because you talked about one of the primary symptoms of iron deficiency being fatigue.
Yeah.
In a perfect world, should we live in that world,
yeah,
all of these other labs that you just spoke about in an ideal world would also be run to like figure out what it is.
100%. Every single one of these can cause fatigue. The only one that's not as specific and direct to that would be the celiac testing. So that one is not something that I always run, but I wanted to put that in a piece here to get people thinking like, okay, someone comes into their office or you yourself have like longstanding gastric issues, which celiac can present in other ways as well. But the more obvious would be like either you're running to the bathroom or you're constipated, etc. Like we need to, if you have digestive symptoms, we need to consider looking at digestion as like what is going there and why is it getting in the way of you absorbing like not just iron from your food, but other micronutrients. But we're just talking about iron, but it's a lot of other things.
You're a wealth of knowledge, Miss Fox.
Yeah.
So it's like you're a doctor. So how often when you see people's labs from their GP, how often do you see all these being run when someone goes in? Like, so they come in, they're like, looking like maybe they're iron deficient. Like, so how
good question.
Often do you see like, oh, like, yep, all
like
these
everything's
things.
been done without me prompting them?
Yeah. No prompt.
No prompt? Never.
Never.
I've never come in I never say never, but like someone coming into my office and I'm like, okay, let's see what they've had run already. Would this full thing be like front to back completed without us having to like be like, okay, we actually need to add this and this and this on? Never. I can say that unless they've seen a naturopathic doctor before, but even in that situation, it's still not all done. And then I'm like disappointed in my people because they're not doing the proper labs.
Where's my people at?
Yeah.
Okay.
Yeah.
So it's good, I think, even for me learning as we're learning to be able to know what labs we run for it, but what labs we need to run to differentiate other things. Cause it's complicated, right?
Yep.
And we've talked about that in so many episodes with women in general. Complicated. Okay. So are there ways to determine if we might have low iron if we don't get labs run? Because the reality is that some people also just don't have access to this. They won't have access to a naturopathic doctor. They don't have a GP. How do we start even like knowing like, oh, my iron might be low without getting blood work?
Yeah. So this is fun. I'm like actually excited to share these numbers with you because it will give you such an obvious way to be like confident that you're not going crazy without actually seeing your lab work or like knowing that you went to see your doctor for this and they're like, hey, everything was fine. But now you will know that it's not fine.
I'm excited.
That's great. So let's go over a few things. So there's a list of numbers, and actually I pulled this again from a course that I've taken through two other naturopathic doctors who run a course in BC called Iron RX that teaches physicians how to do iron infusions in clinic. So they gave us a lot of good numbers and stats to work with. So I'm thankful for that because it would have taken a lot of work to dig all this up. Yeah. Let's just go over it. So let's talk about what we have in our body already, like as like a base, like what are we able to store as far as iron goes in our body? So males store 3.5 grams ish and females 2.5. Huh. And I mean, we're smaller generally speaking, so that would make sense.
The men get more interesting.
I know, I knew that was going to come up, but I feel like it's more about body size than,
who knows?
I don't think our bodies discriminate, but who knows? It's hard to say. Okay. Now let's talk about like what the average person, and I'm not differentiating male to female, but average person consumes of iron in a day, and then what we actually absorb from that consumption. So we're eating about, let's say 10 to 20 grams of iron per day. And then what we absorb from that is only 10%. So though we're getting food, like it'll list like how much iron is in this product, but you're only getting 10% of what it lists because it's about absorption, not what you're intaking, but what you absorb.
What?
And as there's a saying in naturopathic medicine, you are only as good as what you can absorb. So, and this is on a good day, people. This is on a good day with no digestive issues. This is perfect digestion. This is what you're getting. 10%.
I really thought that was different.
No. So now you know.
10%.
10%. So then total, what are we getting a day? It's like 1 to 2 grams per day of iron. Yeah. So that's what you get. So in a month, you get 30 to 60 grams of absorbed iron. So those are the numbers that we're going to work with. And now we're going to go over some other numbers related to blood loss and different things to help you understand then the imbalance between intake versus what we lose, if that makes sense. So this is in part like very female specific when we're coming to talk about periods. But first of all, let's just talk about blood. So 1 ml of blood has 0.5 milligrams of iron in it. So whether or not you're getting a blood draw, like let's say you go to Life Labs and you're like, oh my gosh, they took so many tubes of blood. Yeah. Let's say each tube was a mil or something like that. So let's say they took 5 mils, you've just lost 2.5 grams of iron, if that makes sense.
Which is a big deal if I'm only getting 10% of
So if you're having to repeatedly get your blood work all the time, like I have to tell patients, I'm like, we don't want to over test because you're just draining yourself. Like,
people that there's lots of people that donate blood.
Well, I'm going to get into that because there's some lovely, generous ladies, particularly. Sorry, man, I just haven't seen any man that donates in my office yet, but I've had to tell women to stop. But I see primarily women, to be fair.
I'm sure lots of men donate.
But anyways, we're going to talk about donation. Actually, that was my next point. So when you donate blood, you're donating about 450 to 500 mils of blood. So cut that in half because each mil of blood has 0.5 grams of iron. So you're losing between 200 to 250 grams of iron.
That's a lot of steak.
It's a lot. So think of the deficit. We only get 30 to 60 grams absorbed per month, but you've just donated 250 grams possibly. Like, how do you make up that deficit? That's hard.
Huh.
Yeah, she would take some time, but if you're a menstruating female, which is my next point. So let's talk about blood loss in the menstrual cycle. And this is probably the biggest educational point I'll kind of teach women, because a lot of women come in thinking, no, my periods aren't heavy. They're just like normal. But then I say, compared to what? Or compared to who?
Right.
Right. Mm-hmm. Then I'll quantify. I'll ask how many tampons, how many pads, how many Diva cups, like whatever device they're using. I ask, on your heavier days, how many you're using, then on your lighter days, and then we'll add all the total up and then we'll have a number at the end of it. So let's just talk about like a light cycle on average. So if you're someone who has a light period, you're losing about 15 mils of blood. If you have, let's say, average or just below a heavy cycle, you're losing 80 mils of blood. And if your periods are heavy, you're losing between 80 to 260 mils of blood per cycle. So again, light, you'd be losing about 7.5 milligrams of iron. Moderate would be 40 milligrams. And then heavy at the top end would be 130 milligrams per cycle.
No wonder my ferritin numbers are so low.
Yeah. So if we're talking about, let's say, we don't need to ask details about yours, but we'll just give an example.
You don't want me to get so specific like I did in our last episode?
Let's talk about Amanda's tampons. I'll just give you an example. Let's say that you use 4 super tampons in a day and you do that for 3 days straight. And that's not even accounting for what you're doing at night, overnight, if you're having to get up. So for a super tampon will hold about 10 mils of blood versus a regular tampon will hold 5 mils. A super duper, which is the next size, is about 12 to 15. And then like the ultra is like 15 and more.
Yep.
So we're just using super tampons, 10 mils. It's an easy number to calculate. So if you're using 4 of those a day, that's 40 mils times 3 days. That's 120 mils. That's all you'd have to use to and that's the cutoff for a heavy period is 80 mils. So that's 40 mils over this example that we're using. So it's very easy to like kind of tip into that heavier side, especially if you're going through phases of life like perimenopause where periods can get heavier, or even if you had heavy periods and they get even more heavier, or there be more days, there'll be 10 days instead of 3 days long. You can see how this will add up to iron deficiency. Yeah.
It'd be like 8, 9 in a day. Like that's.
Are you talking from personal experience?
Yeah. She said we wouldn't go there, but I am.
Well, you just said it. I was like, where'd you get that number from?
Tampons. That's wild.
Yeah.
And there's so many women. Like I talk to so many women.
Yes.
That have such heavy periods, and it's so terrible.
Yeah.
Jeez. Okay.
So that's that. And then I think another important piece to talk about is baby making and how much we donate in that process to the baby. I always tell people, I was like, you're literally just giving it all away.
Yeah, like motherhood in general.
Yeah, that's where it starts. And it just doesn't end.
Starts there.
Yeah, it starts there.
Yes.
Yeah. So, so to build a baby, like build a bear, build a baby, you use 1,000 milligrams of iron to build that baby.
Oh.
1,000. So your body stores 2.5 grams.
Okay.
Yes. So milligrams. So yeah, that's using 1 gram. So 1,000 milligrams is 1 gram. So 1 gram of the 2.5 grams you store is donated.
So next time my kids are bugging me, I can say, I gave up 1,000 grams of iron.
Milligrams.
Put your shoes on.
Yeah.
I'm going to use it.
That's the line. They're going to look at you like you're crazy.
Okay.
Okay. So that's that. Now let's just break it down by like first trimester versus second. Because first trimester, like where the damage is really done is when you're bulking up the baby, which is not in the first trimester. Okay. So in the first trimester, we're donating 0.8 milligrams per day.
Okay.
So 0.8 milligrams. And if we talk about what are we able to eat in a day, like to absorb actually, what do we absorb in a day? We absorb 1 to 2 milligrams. So 0.8 of that goes to the baby, but then you also have to give something to yourself. Like we need it too. So even in the first trimester, you might, be breaking even, maybe. And that's pending, like, did you go into the pregnancy with low iron?
Right.
If it was already low, then we already have a problem. Right. And that's actually another stat that I wrote down. 12% of women actually go into pregnancy iron deficient already.
Yeah, I bet.
Yeah. And by the end, about 65% are iron deficient.
Yeah.
And this is based off of reference ranges that are skewed too. Now, third trimester, you're losing 7 milligrams a day. So that's more than 3 times the amount that you're able to absorb in a day. And even with iron supplementation, and this is what we have to say to women, where if we test their ferritin in their third trimester, their ferritin's a 30 or a 15 or whatever it is. We say like you can orally supplement, but that might maintain you where you are, but that will make up the deficit that you're feeling right now. And so truly the only way to get your iron levels back up in the third trimester is through infusion. So you can't out supplement a deficit at that stage. You're just too far. So we can be very preventative in the first few trimesters by knowing the numbers at the beginning of your pregnancy and being proactive in building you up as much as we can before we hit that third trimester.
Interesting. Yeah.
So that's baby building. And yeah, the last thing that I wrote down was about vaginal birth. Then you're going to give out, just because of the blood loss in that process, you lose another 250 milligrams.
Yeah, I bet.
Yeah.
I bet.
So that's baby making and numbers, right? So those are the numbers overall. And then as far as like food, I don't know what I felt like I wrote this down, but plant-based sources versus let's just talk about that. Cause when we're eating meat, we're able to absorb about 15 to 30% of the iron within like a animal source versus in plant-based sources, like you don't get higher than about 15% absorption max. So it's more between the number is closer to let's say 5 to 15% absorption versus 15 to 35% absorbed from animal-based food. So that's why even though spinach, we think of spinach, eat your spinach like Popeye, it's good in iron. That's a good
Tell
example,
me you're a 90s
right?
kid without telling me you're
I
a 90s
know,
kid.
but it's just a funny example, but spinach ain't going to cut it.
So what, tofu versus steak?
Yeah, same thing. It's plant-based. That's like soy. Yeah. So although there's good iron in it, and it'll list the amount of iron, you want to absorb as much out of that iron as you would from an animal source. It's because it's heme iron versus non-heme iron, and supplements are designed the same way. There's heme supplements versus non-heme. Heme is easier to absorb. Yeah. Yeah. These are the nuances of iron.
Heme.
Yeah.
Like hemoglobin?
So heme is just a word to describe animal-based iron source, heme. So it is, you're eating the heme. So when you have a heme iron supplement, it's from an animal. So if you're a vegetarian that, doesn't eat meat for ethical reasons, you're not going to have a heme iron because it comes from an animal.
Right.
So don't do it.
Okay.
Bad idea.
Interesting. Okay. So ways to determine that give us clues that we're low iron. So what, you said all of the ways that we lose iron, but how are some clues just as a human being that we're low?
Well, these are the clues.
That you've given birth, that you...
Well, these are the numbers. Knowing the numbers, you're knowing okay, I'm a vegetarian, I only eat plants and we know we don't absorb them as well. That's a giveaway. You saw my numbers when I was a vegetarian. I ate so good. You can eat the best diet in the world. It doesn't mean that you're going to have B12 or iron because you just can't get enough from that type of diet. And that's not a knock to that diet. It's a beautiful diet. We just know that vegetarians and vegans, they need to get their levels tested and they often need to supplement because it is almost impossible to keep your levels up. If you have that level of flow in your period, that's a sign. You don't need your iron tested to know you're low. Why you need your iron test or your ferritin is to know the number. So you know your base, and then you then monitor based off that level because you can overdo iron as well.
Okay.
So it's dangerous. You can't just be like, I have heavy periods, I'm going to just start taking an iron. Well, no, because you can do harm too if you overdo it.
It's tricky.
Yeah.
Okay.
Yeah.
Okay. So let's talk about optimal land. What's optimal ferritin?
So optimal, and I actually wanted to reference an actual article. So this is 2015. There's an article that came out from the National Institute of Health that reviewed across the globe, like all the various different reference ranges and different guidelines in different like health, like countries basically. And we're trying to figure out like what is optimal, what is ideal, because there's such a variation, whether it's province to province in Canada or state to state in the US. Like each province, a lot of people don't know, but each province has their own healthcare sector. So it's not that Canada's healthcare is governed on a federal level. It's actually provincial, that we get funding from the federal government. Each province, as you know, you lived in Alberta. You're like, why did I test negative here, but positive here?
That's true with a PAP
you
for
did.
cervical cancer.
Yeah. You're like, why?
And I had to get the whole thing. It was really bad. It was so dangerous.
Because of the discrepancy. Yeah. So what was your example with that?
I did my PAP and then Alberta was like, you're good. And then BC, I had to get another one done for some reason.
It was close together, but you were like, why did this say this and there? Like,
and then BC, it was like I had to do the whole
colposcopy.
The leap. They found like it was like bad. There were bad cells in there, and they had to cauterize them out of there.
So that's like different again, like different reference ranges, different standards of practice, different, like it varies, and it's a game of like who's right.
Well, not Alberta, because I might be dead. Not Alberta. I had like almost stage 4. Like it would have turned very cancery very quickly.
Yeah. So that's, I mean, a really scary example of this, but that just is a good depiction of even within a country, how much variation there is in like the healthcare and the type of care you get in different provinces. So this, again, like going back to what they concluded. So this article was called Guidelines on diagnosing and treating iron deficiency, a systemic review. And the conclusion is that the goal they were hoping for people was hemoglobin concentrations that if you treated the iron deficiency would increase by 10 to 12 grams per deciliter. For ferritin, you would be over 100 UGs per liter. And then for transferritin saturation, it'd be between 20 to 50%. So ferritin is kind of what we're using. So here it's like 100 is our benchmark. And the way I describe this to people is if your ferritin is 100 and your CRP is 0, which just because CRP is 0 doesn't mean there's no inflammation, but it's likely not impacting your ferritin number. So if your ferritin's 100, you can be 100% sure that your symptoms that you're experiencing, whether it be hair loss or fatigue or low libido, there's 0% chance that it's related to your iron levels.
Okay.
Versus if your ferritin is 50, you can see how that likelihood would change, right?
Yeah.
So 100 is 100%. We know for sure that your symptoms aren't related to this.
Okay.
Yeah.
So tell me a bit about the reference range. Like if I go to my GP and then I get my ferritin tested, what would I have to be like flagged as bad?
For them?
Yeah.
So the bottom of the reference range for females is 15.
Right.
And that is what leads me into this like next little like journal excerpt I have to read you guys, because that's what this is based off. So it's actually kind of funny. I'm going to read it and then we'll applaud and then we'll also make fun of it. So let's read this. So the Journal of Applied Laboratory Medicine. So this is 2021. I took a quote out because I was like, oh my gosh, I really like what they wrote here. But then I realized the reference ranges that they were referring to sucked. So it said this study highlighted the discrepancy between clinical guidelines and clinical laboratory practices of ferritin reporting and indicates for ferritin reference intervals. So reference intervals means like between 15 to 250, that's like the reference interval. So the wide range that your ferritin can fall within, particularly for female patients, are set to an inappropriately low threshold in most laboratories in North America. So I'm like, yay, like, thank you for acknowledging that. But when they were saying that, they were actually quoting that a lot of the labs set their thresholds actually lower than 15.
Oh.
So if we're talking about having a ferritin of 15, some reference ranges, certain labs will say 10 is the cutoff.
Boy.
Or 7 is the cutoff. So they're saying like standard practice should actually be, the bottom end should be between 15 and 30, which still isn't good enough. But their point is that it should all be standardized to somewhere that's a bit higher, when in reality, like 50 at minimum, and I know there was talks about this a few years ago getting this change, but 50 should be like the bottom of the range. But we still know that between 15 and 100, there can be symptoms. But as far as like severity goes, there's a better chance that you're not as negatively impacted. But as I said, 80 to 100, that's your goal. That's where you wanna sit.
That's where you want to be.
Yeah, that's where you want to be.
So yeah, it's just so much information. It's so good because, and you've said this several times, but like you get your iron tested and then they're like, you're good, but you're good at 15. It's probably not good.
No. And then for men, actually, if we want to talk about the bottom range for them, I think it's 44 or something like that. Their bottom end is a bit higher.
Typical.
As far as being considered low, which is like, again, like you can't make this stuff up.
They have more iron and they have better ranges.
I don't know. Yeah. So
okay. Well, I've learned a lot again.
Yeah.
Yeah. Is there anything else you want to add to this?
I think that's kind of a wrap on kind of the information I wanted to share in part 2 anyways. Okay. Yeah.
So if you have questions, comments, like your story, anything you want to add, like comment. I won't have much to add, but Dr. Fox has a lot to add. And so she can answer your questions. One day we're going to do like a live, like read questions, answer them. So we're here she's here for this specific topic, to talk to about this. So yeah, drop a comment below and thank you so much for being here and listening.
Yeah. We'll see you in part 3.
Bye.
Bye.
Please contact your own healthcare providers before you make any changes to your health and wellness protocols related to your body and mind.